colleagues. Thank you very much for giving me the opportunity to present our paper in UK. I don't have any disclosure. Minimal invasive AVR has shown excellent results in terms of mortality, morbidity, pain, satisfaction, while providing faster recovery, shorter hospital stay, and better cosmetic results. However, there are actually two reviews, one published on ATS and the other one on the journal, focus mainly on ministernotomy. Only few studies have focused on right thoracotomy. Previously, last year, we published our first results with the right thoracotomy, and we reported our series of 192 patients from January 2005 and June 2010, showing excellent mortality, about 1.5%, and low stroke rate, and interestingly, a low rate of atrial fibrillation, about 18%, and a low rate of blood transfusions, about 16% in ICU. Very good results in terms of mechanical ventilations and length of stay. And the follow-up was about 2 years follow-up. Discharge was 90%, which in Italy is a very good results because usually we send patients to a rehab hospital. Excellent survival, and about more than 90% of this patient back home, very good. After that, we compared our results with a matched population undergoing a full sternotomy, and the conclusion were that we found a low rate of atrial fibrillation, blood transfusion, shorter mechanical ventilation time, and length of stay. Because there are no studies who compare the ministernotomy versus right thoracotomy, and actually we do both of minimal invasive approach, aim of our study was to compare the early outcome of the patient undergoing right thoracotomy versus ministernotomy in isolated AVR. It's mandatory that all our patients undergo a CT scan, enhanced CT scan, because it's very important that there are 3 rules. The first one is that the aorta is rightward. I mean, this means that if you consider that white line on the first figure, this means there's a point here? No. More than 50% of the aorta should be on the right side. The distance from the ascending aorta to the sternum should be less than 10, there's a mistake, less than 10 centimeters, and that angle should be more than 45 degrees. Otherwise, if the patients are not suitable for right thoracotomy, our second approach is the ministernotomy. Ministernotomy, it's a V-shaped ministernotomy at the second intercostal space. So we evaluated our patients from January 2005 and December 2011. Of 1,853 patients who underwent isolated AVR, we selected 251 patients undergoing right thoracotomy and 155 patients undergoing ministernotomy, and patients, of course, with full sternotomy were excluded. Moreover, were excluded the patient with a previous cardiac surgery, with history of right pleuritis, because we had some conversion from right thoracotomy to full sternotomy for this reason, and of course, aortic dilatation. These are our baseline characteristics. There were no difference in terms of age and other comorbidity, except for the gender, where there was a higher rate of female gender in the ministernotomy group, and the Euroscore was a little bit low, about 5%, medium 5%, in the range between 3 and 10%. The most procedure, the valve that we used were biological valve in both groups. 13% in the right thoracotomy regarding the mechanical valve, and in ministernotomy the rate was 11%. And interestingly, we started implanting since 2011 the sutureless valve. This is the first series. We implanted 22 valves. Most of them were enabled. Then we abandoned, starting with the Perceval S. And as you can see, one of the most important limitations of the minimal invasive AVR is that we had very high operative times in terms of cross-clamping time and cardiopulmonary bypass time. And the rate of conversion was similar in both groups, and mostly due to bleeding. Results: no difference in terms of mortality, stroke, bleeding, and of course blood transfusion. So we are in line with literatures. However, we had a lower rate in terms of postoperative atrial fibrillation, shorter ventilation time, and ward stay, with a median of 5 days versus 6 days. In conclusion, we can say that all minimally invasive AVR are associated with the low operative mortality and morbidities, faster recovery, and however, we think that patients undergoing right thoracotomy are associated with the lower incidence of atrial fibrillation, shorter ventilation time, ICU time, and hospital stay. Thank you very much for your attention, and thank you for giving me the privilege to stay here with you.